Okay, actually, whosoever is in the training program, uh, sometimes in first year of training, you don't know what you have to do. Different people will say different things. Okay, some people will say start reading first 18 chapters of Morgan. Some people like there are so many confusion in the minds of the residents that what you should do and what you shouldn't do. First of all, anesthesia is a specialty in which nothing you can say. I will quote a word. Anesthesia has very little anesthesia. Anesthesia has very little anesthesia because all the medicine, all the physiology, all the pharmacology, all the anatomy, um, even radiology, you name anything. Even you should be, if you want to be a good anesthetist, you should be knowing the surgical steps as well. You should be knowing simple changes which can occur with the positional change. You should be knowing a lot about equipment. You should be knowing a lot about the happening around it. So actually, real anesthesia. Maybe you can say these the word which I use is gases and everything. Otherwise, medicine is the same medical diseases which we are reading since medical school. Physiology, pharmacology, anatomy is the same. Okay, there is nothing which is changed. So first of all, you just have to gather all that basic knowledge with you, and whenever you are doing any case or surgery or anything like anything you are so you should be just thinking that it you just have to recall and apply the same knowledge which you have before. Okay, so there are some basic steps you should be following, and uh, so I will just suggest you a few things which can help you, like in last setting which we were discussing that, for example, if you have any case, what how will you evaluate that patient? So preoperative evaluation is one of the important thing. Okay, and for that you should be focusing on history in the form of symptoms. Okay, examination in the form of, you can say, signs, and you just have to do some investigations. And for investigations you should have a rationale that why you want to that investigation, and on the basis of these three things you will be chalking out risk factors. Okay, risk factors, mainly cardiac risk factors, renal risk factors, respiratory risk factors. Okay, risk factor for PONV, risk factor for aspiration. Okay, risk factor for difficult airway, and you can just make on a list. Okay, so like this is the first step you should be focusing, and actually it has the basic principle of the same knowledge which you have from your medical school. So you should be focusing on the same thing, and ultimately because why cardiac is important, because whatever medication you are giving is can have cardiac depression. Whatever medication you are giving, it will be metabolized by liver and excreted through kidneys. So anything which a number of factors which will be there in the intraoperative period can damage the kidneys. Like what will be the important that if the patient is having a surgery which will be lasting for a long time, this is a renal risk. A surgery in which there can be a lot of bleeding, this is a renal risk. A surgery in which there will be hypotension, this is a renal risk. If patient already has some disease which can cause some baseline renal dysfunction, this is a renal, like diabetic patient is a renal risk. Chronic hypertensive patient is a renal risk. Patient taking AC inhibitors is a renal risk. Things like that. Okay, so you will be just trying to, whenever you are so this is a message for the basic resident, and actually this is true for all of us. Whenever you want to like some you just want to uh, have a better plan of management for your patient, you should be doing in the same steps. Your mentality should be in the same way, that you should be knowing why this surgery is happening, and whatever sign symptoms you get from the patient, you ultimately you have to give anesthesia. So you have to know that what are the risk factors in these patients, okay, and then you will chalk out your plan accordingly. So this is the thing which you should be, you should actually, I have just formulated as, like, it's not a perfect one, but in this document I have just made a journal plan which you can use in majority of cases. Okay, so it will just open up. So, okay, so I have discussed this the number of times. I will share this, and you can have a look on it. So there will be some aspects which is related to the medication, the medical disease which the patient will have, the age group or any physiological state of the patient. Okay, and then on the basis you will be just evaluating the risk factors. Okay, and there will be something which will be related to the surgery. So what is the urgency of the surgery? What is the surgical risk, bleeding risk, anything which is related to the patient positioning, duration, level of anesthesia. Like this will give you an insight that, for example, if you just hear from the surgeon that we want to do an appendix, okay? So you will be thinking about appendix this as a procedure, how this procedure is happening, what will be whether they are doing open or laparoscopic. Okay, and then you will be looking at the patient condition or any other medical disease, and ultimately your aim is to rule out any airway problem, cardiac problem, respiratory problem, problems related to liver, kidneys. Okay, so like if, for example, if there is some bone marrow problem, so there will be cell lines will be disturbed, patient is anemic, or patient have any coagulation problems or things like that. So if you don't organize your thinking, you will miss. Okay. So you just make your life easy by making this. You can actually, this is because I have just made it by my mind. It's not copied from any source. This is purely my thinking. You can edit it according to your understanding, and you can add some things, you can delete some things. My suggestion that all of us, of course, when we are in practice, so this becomes our second habit. But for residents, I will highly suggest you that you make a paper like this and always fit whatever surgery or whatever case you are dealing in these headings. Okay, so whatever you find, you just try to fit in these points or these settings, because whatever you will be planning, that how you should induce, how, whether you should give some pre-medication, what monitoring you should be doing, what induction agents should be, will be according to the situation or scenario you have. Okay, so whatever you will have some information, you will interpret, you will need some investigations, and according to the urgency of surgery, you will either optimize the patient, you will defer the surgery, or you will proceed. What monitoring you will be needing, how will you maintain the airway, how will you maintain the anesthesia, what position surgery will have. So this document, I have just tried to, that whatever we are doing, it will be evaluation on the basis of history, examination, and investigation, risk assessment and stratification, optimization of a medical condition, anything you can optimize. Even for example, if you have a immediate surgery, optimization also means just you are taking 2 3 large bore IV cannulas and starting fluid. That's optimize. That's what optimization or management you can do immediately. You have a patient with COPD, they're going for any emergency surgery. Even then, in the holding area, before you shift the patient, you can nebulize the patient. You can give some chest physiotherapy. Okay, so there are so many things according to the situation. You will think, anything I can do now. You have 5 minutes, or maybe 5 hours, or maybe 5 days, or maybe 5 weeks. This will be depending on the scenario. and surgery you are taking, but the basic principle will remain the same. Okay. And then you will be anticipating some of the complications. So this you should be your in your mind, that what complication can occur. Just I'll give you an example, that you are doing a dental surgery. So usually dental rehabilitation or dental clearance will be either in patients with poor hygiene, bedridden patients, patient with neurological problems, cerebral palsy, or any Down syndrome or things like that. This will be one patient category. There may be one patient category in which the patient has very bad caries or something like that, and he or she is not accepting to be done in local because painful, phobia, and this and that. So this will be second category. And third category will be patients who are going specifically, usually, cardiac surgery. Okay. So cardiac surgery patients usually, because they are at risk of infective endocarditis, so these patient group will be coming for dental clearance. So whenever there is any surgery, think what is the reason for that surgery. Okay, there will be some specific patient groups usually for specific surgery. So you should be in your it should be in your mind, what is the, because what the surgeon is telling you or what information you are getting is only the tip of iceberg, and you just have to explore from there on, that why they are doing this surgery, why it is happening. Okay. So with passage of time, you will not find these things in clearly written in books. This is what is your approach will tell you. Okay. And this is what you should learn, that if you make your approach correct even from the first day of your residency, believe me, your you will get better and better. I like because of course not everyone is in the same work environment. You will, but you can make your own approach, and don't be afraid. Don't underestimate yourself. You are a doctor. You are, even if you are doing training, you are first year residents. You are not a baby. You have read all. You have worked enough time in medical science to know what how to take the history, how to evaluate the severity of any problem, how to evaluate the systems, the respiratory system or cardiovascular system or renal system, whatever. So this everyone knows. Nobody can say that I don't know how to evaluate respiratory system. Okay, so I have actually done too much details. Every system we did separately, how to approach, and you can find these recordings in the playlist. Okay. So this is the basic thing. Okay. And then you will chalk out, and then in the operation theater, I will suggest you that if you are a first year resident, you don't have enough knowledge or experience for that thing, just you should have a copy in your a small notebook, or now as of 2023 you can have your tablet or anything, and just make note or make points which you want to explore. Okay. So as I was telling you that maybe you will just explore that this as I told you about dental surgery, that the patient group you realize, and then you think that it is the same concern like in ENT or anything, shared airway, throat pack, nasal intubation, dental injury, okay, tube dislodgement and anything, tube kinking, and post-operative pain and post-operative, like, so there are certain specific points you should be thinking, that this is these are the main points about that surgery. So then you can explore, you can read about those things separately, and you can explore. There will be because if you make your approach correct, believe me, ultimately you will learn. So actually, this is just a template you can edit according to your understanding. I have, like in this folder, I have just like put some common things which you should be doing. Okay. Even this document was about preoperative testing. You can have some information that how what because you should be knowing whatever testing you are doing, why you want to do it. Where people ask, like, if I ask this question to any of you, please just tell me why you want to do echo. Just tell me just one good answer, please. Or anyone wants to answer. Asif, would you like to answer this question? You found a patient with
Yes,
hypertension.
sir. I would,
Yes. Why you want to? What you want to
sir,
see in echo?
I want to know about cardiopulmonary, cardiac reserve and cardiac function of the patient. Like
Okay.
I would, if there is any pathology like hypokinesia, low ejection fraction, or something with the stenosis like that. I mean, cardiac issues. के लिए देखें.
No, of course, echo is for cardiac, but what in cardiac?
Sir, I will pay attention to ejection fraction of the patient that whether ejection fraction is enough to well perfuse the patient, which is gonna through the GA, and
Okay.
I will see any stenosis or any regurg in the patient that is related to valvular disease.
Okay, actually, if you just think, I have just chalked out during your answer, you just have to see the systolic function, diastolic function, chambers,
Yes, sir.
valves, filling pressures, pulmonary pressures, and signs of ischemia with reference to either segmental wall motion abnormality leading to
Yes, sir. Global
hypokinesia,
hyperkinesia.
akinesia. Okay, so ultimately, you will be looking according to the like for example patients sorry people are looking at ejection fraction. Believe me, hypertensive patient, ejection fraction is the least important thing in hypertensive
Thank you,
patient.
sir.
If it is more than 55, it doesn't mean that all is good. In hypertensive patient, which is more important, is diastolic dysfunction. Okay, because ejection fraction will only be decreased at a later stage, not in the early stage. But in hypertensive patient, as the hypertension grows, there is growth of the heart muscles and there is hypertrophy, and then actually the heart muscle is getting angry. So the heart muscle is not receiving the blood nicely. So this is more important than ejection fraction. And you are very happy. Maybe patient has grade 2 diastolic dysfunction and ejection fraction is more than 55, your say heart is very good. Heart is not very good. Okay. So, like I'm just giving, actually, I had a very detailed discussion purely on echo. So you can have a look. I'm just trying to give you an option that whatever you are doing there, you should have a reason. Okay. You should have a reason why you are doing that investigation. Okay. So because the next step will be if you like this thing actually I have written here: chamber size, chamber pressure, chamber clot, wall thickness, valve size. Next step will be how to see the ischemia. So if you find some segmental wall motion abnormality, then you will go for thallium scan. You will see, or you will do exercise tolerance test, or in these days CPEX testing. According to the scenario, you will be doing whether there is some ischemia, because like if there is a segmental wall motion abnormality or hypokinesia, there may be a reason for it. Either the patient already has got some infarction and that area of the heart is dead now, or there is some ongoing ischemia which is maybe correctable. For that, you will see the thallium scan to see the perfusion defects, and then you will go for angiography to see which vessel is blocked and whether it can be done by the balloon only or stunt only or patient needs cabbage. Okay, this will be decided only with the start with these things. So actually, I have just you can have a look on this. Of course, I'm sure majority of people, unfortunately, they don't have time to see these things. But I assure you that if you have a look at it, you will definitely get benefit. Okay. So these are some of the basic things. And that day we were just discussing. I will just try to repeat some of the things which we discussed. That like this is like how patient has NPO. So we just thought about what will be the consequences of prolonged NPO. So that patient will be dehydrated. Okay, if you not properly, this patient will have some electrolyte imbalance. Okay, this patient will be at more risk of PONV. Okay, this patient will have at more risk of ILS. that patient will have at more risk of wound impairment. Okay. If you are not giving proper fluid, uh, then this patient will have problem with the anastomosis. Okay. This patient, this patient, if they are doing any graft, okay, graft, if you are not able, the graft will have problem. This patient is have like wound impairment and also surgical site infection. So if you are, the patient is NPO for 10 hours and you don't anticipate there may be exaggerated hypotension. Okay. So like everything has got its importance. So whenever you are evaluating any patient, you should be knowing what will be the sequence and what will be the sequelae. Okay. So similarly, uh, we discussed about use of dexamethasone. Okay. What is the advantage? We discuss about use of multimodal analgesia. Okay. So actually, whenever you are approaching any patient, the basic thing I repeat, and finish off my discussion, which I just wanted to, whenever you are receiving any call, you will have identity of the patient. Identity of the patient will be young or old or female pregnant patient, okay, or smoker. This will be the identity of the patient. So there will be some concerns which it can be any, you can increase it. Alcoholic, it may be alcoholic, it may be like drug addict, opioid addict. Okay, so this will be the patient identity. You can say any occupation. So that will be demographic, patient demographic. Okay, this will be one thing. So smoker, you are expecting respiratory problems. You are expecting uh, like cough and everything. Okay, so this will be in your female patient. So it is more risk of PONV, female patient. Okay, there is more like you have to rule out pregnancy. So there are so many problems which will be like if you have a female of 55 years old, you are expecting menopause, postmenopausal syndrome. So that patient will be at risk of hypertension. Okay. So they you will be if you have an elderly patient, so there will be concerns related to old age. So according to the patient identity, that is the basic thing, the patient demographic. The number second three thing will be disease. The basic disease, the basic disease the patient has, the basic reason for the surgery. This will be one thing, and the co-pilots, the comorbids. This will be the second thing. Maybe some patient will have a lot, and some patient will not have anything. So the one concern, and then third concern will be related to surgery. And then all on making consent, you will make the risk factors and risk stratification. Okay. And then you will make a plan for anesthesia. And the steps of anesthesia will always remain the same. Preoperative evaluation, chalking out risk factors, then pre-medication, anxiolysis, or maybe stopping or starting of any medication, or correction of anemia, or whatever. This will be the same. And then the steps of the anesthesia, monitoring, induction, maintenance, analgesia, fluid, lines, urine output, temperature monitoring, and then where you are sending after the patient. So for all residents, this is my request. Make your plan like that, and then gradually you will fill in the gaps, and then you will learn. So one mode of learning is don't open first 18 chapters of Morgan and try to cram. You will not learn anything. I can bet i can bet on it. Okay, make your learning goals. Okay, and then it will be easier for you to approach rather than just going blindly. Okay. So thanks a lot, all of you, for your presence. And I repeat this thing again and again. You all are welcome, especially the residents are welcome to ask any question anytime. Just drop a message on WhatsApp and I will respond. Okay. and all the recordings are there in the YouTube. Number of topics which I told you today, you can just have a look here in this in this channel you can find, and the links which I share. There are articles in one of the link, okay, and there are books of all topics. You just open here, and then you will find basics review books, clinical review books, ICU books, MCQs books, SAQs books, physics equipment books. Actually, OSCE books, people will be saying that when we will reach the OSCE, only we have to do. No. OSCE books, you will find very, very simple things which you will be facing daily. So it is highly recommended for you people to have a look every now and then. Okay. Especially the residents who are just in early days in of their training. You should be, you should make your learning with disease, with equipment, with critical incidents. Start from hypoxia, hypercarbia, arrhythmias, tachycardia, bradycardia, okay? PVCs. Make your own list and just try to chalk out, fill in that what you should do, how you should approach. So this will be give you the big because hypoxia for any reason, your approach is the same. You are calling for help. You are making 100% oxygen. You are just making sure your patient's ventilation is good. And then step by step, you are seeing that whether there is something associated in a package deal like hypoxia with bradycardia, or hypoxia with hypotension, or hypoxia with cardiovascular collapse, or hypoxia only because pulse oximeter had moved. You are thinking that saturation has fallen down, okay, but actually maybe patient is cold and pulse oximeter is not reading, the graph is not coming nicely, but your approach will be the same. You will make 100% oxygen, you will try to ventilate, you will see whether the bilateral ventilation is there, you will increase the FiO2. So your approach will be the same, okay? And then further you will be learning that there may be tube is kinked, you maybe the circuit is disconnected maybe. So your approach will be the same. So try to make list of these specific things which you face almost daily, and then do troubleshooting. And I am there for everyone and anytime. Okay. So thanks a lot, all of you. And 150 topics. Yes, 150 topics are there also. This is just a hint, not an absolute thing. Okay, everyone. Thank you very much. Inshallah, we'll meet again. Bye bye.